Hey, welcome guys to Dennis Insider. Let's talk about cancer pharmacology today. So first, let's do the outline. Today we're going to talk about first is just defining a cancer, the basics of a cancer, what causes cancer, so the etiology of cancer. Then we have the s- the normal DNA, cell cycle replication has repair mechanisms. Um, First at G1 and S phase, and then after S. So we need to see what those errors that can cause cancer. Then we have four types of cancer treatments, um, such as radiation, surgery, we have palliative care, and then we go into the administration route for and the properties of cancer drugs. Um, and now we talk about basically the bulk of the lecture, which is the types of cytotoxic drugs first. So we have the antimetabolites that attack the S phase, and then microtubule destabilizers and stabilizers that attack the M phase. Then how we are using this DNA damaging drugs, these drugs that are, the point is to attack rapidly dividing cells. So how do we use that as a treatment? Then we have antibody drug conjugates, which are more specific, local, have a larger therapeutic index. And then finally we have molecular drugs, such as Gleevec, and they're very limited in their approach, but we have some proven examples of that. Finally, another mechanism rather than we just discussed was attacking the cancer cell. Now we can attack the microenvironment in and around a cancer cell. So we have angiogenesis, where the cancer is able to use the capillary system, make new capillaries, blood supply, and angiogenesis to metastasize. Um, we have immunotherapy, which is basically based on the checkpoint inhibitors. And lastly, we have how is cancer able to form resistance, and then how can we have drug resistance and inhibit or basically prevent drug resistance. Alrighty, let's do it. So number one is defining a cancer. This picture is just showing how a cancer is formed. So we go from a normal cell that's proliferative, goes into hyperplasia, dysplasia, cancer in situ, passes through the basement membrane, basically invades, and then now we have something called cancer. The etiology of cancer is based on these normal genes that are present in a normal cell growth. We have oncogenes, but increasing or gain of function um, in cancer causes those cancer cells to proliferate rapidly. So that gives them that characteristic. Or we can loss of function or inhibit tumor suppressor genes, and that will basically um, reduce cancer, but we are more focused on the oncogenes, which are dominant. Etiology of cancer, we have three types. We can have it inherited, such as in breast cancer, BRCA, DNA repair pathway. We can have mutations, uh, genetic lesions, basically translocations, duplications like that, or set things like carcinogens that cause mutations, like smoking. And then we can have viral agents like HPV and EBV that are able to cause things like some form of oral cancer. So just reiterate everything. Cancer is basically a DNA alteration that causes abnormal cell progression by that gain of function of oncogene and decreasing of the tumor suppressor genes. Fine, and then we have normal DNA repair mechanisms in place everywhere from starting from G0, G1, S, G2 phase. Um, so if we have mutations there, that can also lead to, that's another etiology that can lead to cancer. So we have about normally 20,000 mutations per cell per day in a normal cell cycle. So in breast cancer, for example, the repair gene is called BRCA1 and 2. And if we have a mutation in that, that can lead to cancer. So basically, etiology would be increasing oncogene, increasing your tumor suppressor genes, these types of inherited mutations or viral, and then also once we're already an adult and we have these cells, we can have a higher chance of getting a cancer if our repair genes get damaged as well. Now let's talk about all the cancer treatment. So that was just basics of cancer. So cancer treatment, once again, because these are rapidly dividing cells, they sometimes don't follow the checkpoints. They go crazy. We can use surgery, which is mostly to remove a localized tumor. It's to prevent further growth. We can use it to diagnose the cancer by taking a sample, relieves the side effects, and it's basically to debulk prior to these other therapies such as radiation and chemotherapy. So in radiation, about 50% of patients have to have radiation. We have two types. We have neoadjuvant and then adjuvant. And then this one is basically the one you can give before surgery or after surgery. That's what that means. There's two types of radiation. We have external, which is your beam, and then internal, where we put an implant. Next, we have chemotherapy that everyone knows, and this is more to attack disseminated tumors, whereas surgery was more localized. Chemo is more for disseminated tumors. It's a systemic drug. We combine all of these together. So the whole goal that I forgot is cancer treatment mostly comprises of everything together plus drugs. So you want to attack as many pathways as you can, because sometimes we don't know the specific pathway for a cancer, so it's just better to cover all the bases so they don't have any way to grow, right? And these drugs, chemotherapy, are more to extend the life. And then lastly, we just have palliative care. So some properties about these drugs is that they are given in something called MTD, which is your maximum concentrated dose. Once again, we combine all of these therapies to reduce resistance and cover all the bases. Two types of route of administration is we can have IV, which is supervised because of the narrow therapeutic index, and we just want to make sure the patient gets the right dose at the right time, and that's supervised IV. Then we have oral drugs, which are given either hormonal or kinase inhibitors. And that's something important in cancer or just cell, is that kinase receptors, they're very important in a cell cycle, to start from, like, for example, from G0 to G1 with the growth factor. So anytime we can hit early on, the better it is. Okay, next here we just have overview of the antimetabolites, but first I'll just say there's two types of cytotoxic drugs we'll talk about. Antimetabolites, which disrupt DNA, and then we have microtubule drugs, which are antimitotic for the M phase. So here in the picture, that's what's showing. We have G1 phase, where everything is replicated besides the DNA. Then we have a checkpoint between G1 and S. And S phase is where all the chromosomes are duplicated. So here we can, as the first time, we can basically have a drug target. So those are antimetabolites, DNA damaging or DNA disrupting drugs. Then G2, and then in mitoses, where the microtubules have a high function, microtubule drugs, destabilizers and stabilizers, are able to prevent it from progressing in mitoses. But you have to understand that these drugs are at the phase itself, so it's already in a phase that's in, basically, right? Like, so DNA damaging antimetabolites, they have to be in S phase. It's not attacking in G1. And same thing for microtubule. It's already in mitoses, and it's just not going to finish mitoses. But it is in mitoses. So let's talk about antimetabolite drugs. Here I have 1 through 5. So real quick, overall we have ankylating agents such as cyclophosphamide. Don't know mechanism of action, but they're to treat lymphoid lymphomas and leukemias. Then most important, like more common, are the platinum drugs, cisplatin, carboplatin, anything ending in platin. These cross-link the DNA and they inhibit the DNA growth, so makes it a perfect antimetabolite. More for used in head and neck cancers, but the important part is that they have cytotoxicity depending on the drug. So we have neurotoxicity and nephrotoxicity. Let me just decrease that. Neurotoxicity and nephrotoxicity from cisplatin, whereas carboplatin is more for myelosuppression. And then it also has hearing loss as a side effect. Then we have intercalating drugs, and then these are basically drugs that intercalate into the DNA and disrupt the topoisomerase 2 replication. So another way to inhibit replication. These are natural soil bacteria, drugs based from natural soil bacteria, treat leukemia, lymphoma, breast, lung cancer. But once again, the main part is that they have cardiotoxicity because of the toxic mitochondria in the cardiocytes, so you get cardiomyopathy. And then once again, if a drug is natural, it's not able to cross a blood-brain barrier of some sort, so that's why we won't see mostly like neuronal side effects or central nervous system side effects. Here we have topoisomerase inhibitors. So basically, intercalating is also a type of that because it's disrupting a topoisomerase replication, but more the unwinding of the topoisomerase is by this drug called topotecan, however you say that. Then we have antimetabolites, which we have done before in another video, and I'm going to bring that back. So antimetabolites, 5-FU methotrexates, and these are thymidine synthase inhibitors, so they prevent all the precursor that you need for cell replication, so the cell's not able to grow. But here we have side effects such as inflammation, CNS damage, diarrhea. Then lastly, once again, if we have a repair inhibitor that was happening either before G1 or after G2, then we have drugs called PARP inhibitors. Real quick, we have ankylating agents, cyclophosphamide, and these are basically promoting DNA damage. And then we did all the other ones. Here we have the cross-linking. Here we have the intercalating. Here we have the unwinding or topoisomerase. And then antimetabolites is basically blocks the building blocks. And then finally we just had repair. So these are just like overall mechanisms, how I think of it. And then the side effects that we just did. Now coming to the easy ones, which is just microtubule drugs. So we have the microtubule. Side note is that they're used in every type of cell for trafficking and as a signaling highway. So neurons, every kind of cell. And these are antimitotic agents, which work in the M phase, like we have in the picture above. So their mechanism of action is inhibiting cell division. Antimitotic, M phase inhibition. They are effective, so they're very generic and they hit everything. It's like a bomb. So they can hit the rapidly dividing cells, prostate. They can hit slow-growing cells like breast cancer. They can hit non-dividing cells like neurons, because most of these cells are using microtubules in some sort. So in the picture on the left here, we just have normal microtubule function, where we have microtubule separates the sister chromatids. If we don't have that, then we don't get cell division, basic. So the two types of drugs in microtubule drugs is the microtubule destabilizers and stabilizers. So destabilizer is the vinca that is natural, comes from the plant. The mechanism of action is that it unpolymerizes those microtubules, which basically causes a loss of them, so nothing is able to separate or use microtubules. Treats a variety of cancers, leukemia, lymphoma, mostly pediatric cancers. Then the stabilizers have the microtubule there. They are all bundled up microtubules, so they can't pull apart. And then once again, same kind of effect, that the cell, no type of cell is able to replicate. These are more important in head and neck cancers. The side effect for these drugs is something they call CIPA. So first I'll just do the basics one. We have bone marrow function, GI disturbances, alopecia, but more important is a peripheral neuropathy, which is C, chemo-induced peripheral neuropathy. And here we have feeling of numbing, tingling, pain, burning. So it starts on the fingers and spreads to the body, something they call the stocking effect. It has a cumulative toxicity, and once again, this is a peripheral, not a central nervous system, because these natural drugs are not able to cross the blood-brain barrier. So just picture just shows the same thing. CIPN, they cause nerve damage away from the brain because it's not able to cross a blood-brain barrier, tingling, pins, burning, sensitivity to hot and cold, difficulty with the motor skills. Symptoms are usually symmetrical, so it starts in the finger and progress to the body. Alright, so those were two types of drugs we just did, the microtubules and the antimetabolites. Now we just talk about how are we using the DNA damage as a type of treatment. So all of those drugs basically cause some type of DNA damage, but a layman, a simple person would say that how does this not cause damage to every type of cell and basically kill a person? So the cancer cells, they have already undergone extensive accumulated damage. So if you hit them with more damage, we can push them past their basically threshold, their pathways that they can take. So if you block every roadway that they can cross, then we can kill the cancer cell. And this concept that's important is called synthetic lethality. So that shows in the picture below is that we had a normal gene, such as a repair gene for breast cancer, BRCA. And in cancer cell, if we already have a mutation in BRCA1, that there is no BRCA, and the cell is not able to, and if we mutate or hit this gene B now, and the cell has nowhere to go, and it's basically synthetic lethality, where synthetically we know it doesn't have one gene, and we hit the other gene, and we know it's not able to survive. Whereas a normal cell, it can, even by inhibiting gene B, it's showing that we still have gene A, and the cell can survive. So all the drugs that we just talked about were very generic, but if we need more local targeted approach, then we use the antibody drug conjugates, and these work by local IV administration or targeted chemotherapy because they have a larger therapeutic index. Now let's just look at this picture, and this is how they work. So here we can have a mechanism that's used by lymphomas, but it's also same in breast cancer. So in lymphoma, there's a marker which is the CD30. We have a receptor, and then we have a CD30 antibody, and then this is a drug. So we first get basically the CD30 antibody, which has to work naturally but to bind to CD30 receptor. We want to use that by adding the drug, which is the microtubule destabilizer. So I'll just put microtubule destabilizer, MMAE. And so once this drug and antibody bind to the receptor, then we can have basically it enters the cell, phagocytosis basically. And then the drug MMAE is able to cleave off the CD30 by something called the cat spin cleavage. And that's it. And then the cell, the MME, which is a microtubule destabilizer, will not basically destabilize the microtubule. So far we have done our two types of, we have microtubule drugs, and then we had the antimetabolite drugs. And then we talked about how we use the antibody drug conjugates, so such as the MME using the CD30 antibody. Now we have more molecular drugs. The case study here or example here is with Gleevec for CML. The problem with molecular drugs is that they only target one pathway. So we find out the pathway and then we attack that rather than just a broad approach that we did with the antimetabolites. So with CML, there is the BCR translocation, so single translocation event. They call that the Philadelphia chromosome. Makes a hybrid gene fusion protein, the BCR-ABL, that drives CML. So if we can inhibit the BCR-ABL, we can basically cause a inhibit the cancer, right? So the Gleevec is able to bind in the body. So I'll just write that. So Gleevec binds in the pocket, and there's 100% remission. But once again, this can be used for drugs that are using multiple pathways. Next, we talk about, so those are all the drugs, and now we're going to talk about how can we alter the environment the drug is in. So I'll just do an overview first real quick. So drugs for the microenvironment is we can first attack angiogenesis, and then we have immunotherapy by using the checkpoint inhibitors. And that's it. And then just a new one that's called the CART treatment. So in angiogenesis, we have two types. Here in the picture is going to show you we have a monoclonal antibody that's inhibiting VEG, vascular growth factor. Then we have a tyrosine kinase inhibitor, which is inhibiting the kinase. So that's down here. But both of these end up with the end result of inhibiting endothelial and increasing vascular permeability. Sorafenib is better. These drugs are used in between chemotherapy to prevent regrowth, and more important, this is a progression-free and not a survival drug. Adverse drug reactions, hemorrhage, clotting, wound healing. So angiogenesis, adverse side effect, hemorrhage, clotting, wound healing. Then we have a little complicated, the checkpoint inhibitors here. So checkpoint inhibitors are used when the tumor cell, how it evades immunity. So how can we not let it evade immunity or cause T cell inactivation? So we have two types. We have the CTLA4 drugs, which bind T cells bind to the dendritic cells. Then we have PD-1 antibodies or PDL1 antibodies that basically T cells to tumors. So that's what's showing in the picture here. Basically, we have CTLA4 blockade, and the cell is not able to have a T cell activation. In this, on the PDL, we have a better picture. So here we have first is normal, where we have the MHC class that's inhibiting, basically activating, and so that's the this is what our professor likes to call the gas. So the gas of the tumor cell to inhibit tumor, and then we have this is how the mechanism works that we are the cancer is using to not inhibit the tumor, and finally the last one is what we want. So let's just talk about that real quick. So here we have the T cell to MHC, but then there is a PD and PDL1 that are bound, and if those are bound, the the tumor cell is able to evade immunity and tell the T cell to inactivate, and it's able to just live happily ever after. But if we have these drugs, anti-PD drugs, they will bind to those receptor, and now the T cell or the tumor cell. This is a tumor cell. The tumor cell is not able to evade immunity, and this will activate T cell, and then you can inhibit the tumor. So like CTLA4, they were found early, and they're used in cancer basically to bind to CTLA4, right? CTLA4 inhibitor, which binds to these receptors CD80 and 86. That will basically suppress the T cell activation. And then this is basically, these inhibitors are used to keep the immune system on so it can fight the tumor. So here we're trying to fight the tumor. In PD and PDL, it's similar in the way that we are taking the brakes off, so the tumor is not able to evade detection. And they are used in more cells. So more cells express these PD. So it's a better treatment, right? Now we just finish off with CART treatment, and it's basically where they take your cells, reprogram them, and then put them back, right? The side effect and the side effect here is that it's $1 million. There is a 40% remission, but 90% causes cytokine storm, hypersensitivity. Finally, we talk about the cancer cell, how it's able to form resistance, and then we talk about the drugs. So in cancer cell resistance, here we have a durable response, which means that we had a cancer growth here, but we hit it with a drug, and the cancer is able to shrink, and the person lives. We have innate resistance, where we had the cancer, all the cells shrink, but one cell in the yellow is resistance, and this resistant cell is able to grow, and now you have a new resistant tumor, and then same step follows. Then maybe these other ones will get blued out, and then you have one more, and then that keeps forming resistance. Then we have acquired resistance, where we have a conventional chemotherapy worked, but the DNA agent caused a mutation in itself, rather than having a cell that's resistant, but now we caused a mutation, so it's acquired, and now you have, once again, a resistant. So from here, it can basically go have the innate, where one is left, and then basically same process. So cancer cells that are able to be resistant, we know that cancer cells that are slow growing are able to be resistant, the ones that pump out drug, and all of them that evade immunity, which is really big. So the mechanism to hit the drug resistance from cancer is that we have certain drugs that have specific binding sites. So for example, if you mutate the kinase site, if the cancer mutates at the kinase site, we can then mutate the drug's kinase site and to hit the cancer better, and then just keep repeating that, kind of like the flu vaccines, where we're always one step behind. Here, in upregulating a complementary pathway is that a cancer cell is able to use multiple pathways. So if we can inhibit all these pathways, we can basically knock out the cancer. Finally, the multi-drug resistance is that some drugs are able to have a efflux, or some cancers are able to have efflux pumps that pump out every and any drug that they encounter. So this is just very complicated resistance to tackle.